We're going to start talking about alterations for GI patients, things that happen in the gastrointestinal system. A lot of you have experience with this. This is usually the easiest unit that I get to teach because you or someone in your families had these types of issues, usually. Okay, so in our GI section, we're going to talk about the esophagus, the stomach, the small intestine, its three parts, duodenum or duodenum, however you want to pronounce that, jejunum, ileum. We're going to talk about the Tri-City organs. I refer to them as the Tri-City organs, the liver, the gallbladder, the pancreas, and the large intestine. So that's going to be our discussion for the rest of today and next week, going over the normal function and pathophysiology. All right, so let's make sure that we understand some of the key words that are used to describe GI problems. All right, number one, reflux. If we hear that a patient has reflux, that's usually referring to backward movement of something. All right, in GI patients, it's usually the stomach contents are coming back up into the mouth, like with GERD, gastroesophageal reflux disease. But that word reflux means backwards. Distension means that the abdomen is distended. Now, I was telling a group yesterday, whoever of you I had yesterday, do not go into the patient's room and say, wow, your belly looks like you're 9 months pregnant. That looks really distended. Do not do that. That might be normal for that patient, and if you've just opened mouth and inserted foot, you're going to spend the next several hours trying to reestablish your therapeutic relationship with that patient. So a good question to ask is this normal for you? That makes everybody feel good. That puts the patient in control, and you get the information that you need. Right? You come in, you see they're here for a small bowel obstruction, you see that belly, and you just assume, and that might be their normal, and so don't do what I've done more than once. I'd like to tell you I've only done it once and I learned the lesson. No, of course not. Be smarter than me. Okay. Obstruction. Obstruction means a narrowing or a blockage. The other word that also means obstruction in the GI tract is ileus. I-L-E-U-S, ileus, refers to obstruction, means the same thing. Okay, narrowing or blockage of movement of contents. Inflammation, we can have inflammation from some sort of a food that you've eaten, or we can have inflammation because of cancer. If the patient has a GI cancer, that can cause inflammation. We can have different diseases that cause it. Malabsorption. Most people who have a malabsorption know this. They live with gas, bloating, and what comes out the other end oftentimes looks like what came in this end. It comes out looking much the same, or parts and pieces that didn't get digested come out. It's like, wow. If you have a malabsorption syndrome where you don't absorb fat, that's a problem. And what comes out the other end is fat, and we call that steatorrhea. That is a bowel movement that's mostly fat. And of course it floats, right? Because it's not going to mix well with water, and it makes everything shiny inside the commode. It's like, wow, that looks like we just laced it with Crisco. Well, that's because it was, right? So malabsorption syndromes are readily identifiable to the patient and to the nurse. Okay, you get the drift. Nutritional excess or deficit. Patient may be with extra weight. Patient may be deficient of weight, depending on what the issue is. All right, some of the causes or other words. Neoplasm means cancer. Those patients usually show up with an obstruction. I'd like to tell you they have intense pain. They usually do not. When a patient has a tumor growing in the belly, they don't usually experience pain. They come to us because they can't have a bowel movement. They're experiencing a bowel obstruction. We hope that it's just constipation. We scan the belly, we see a tumor. And that's one of the rule-out things that we have to do before we start treating a possible bowel obstruction. It determines the treatment. If the patient has a cancer, we're not going to be aggressive in trying to unstop them with a plunger, with Drano, with whatever we're going to use to open up the pipes. If it's a cancer, we don't want to do that. Why? It can cause metastasis. It can cause stimulation of tumor growth. So when we have an obstruction, one of the first things we do is CAT scan the belly to determine if it's cancerous. That will determine what route we take in treatment. Okay, ascites has to do with having fluid collect in the peritoneal cavity. How do we assess for that? We put one hand on each side of their belly and we go tap, 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 tap. And if it's fluid, you will see a wave. You will see a wave. And when they move from side to side, that fluid will shift based on gravity. If it is Budman, you tap, ooh, it's not going to make a fluid wave. It's just a solidness, right? Okay, so knowing the difference between ascites and Budman, that's helpful. Jaundice is the deposit of well, it could be bud girl too. Let's not make it like I'm being sexist here. Bud man or bud girl. Okay. Deposit of bilirubin in the skin, we call that jaundice. The other word for that, the adjective, is icteric. I-C-T-E-R-I-C, icteric, also means referring to deposit of bilirubin in the skin. Okay. This we will see in patients who may have liver dysfunction, because the liver is responsible for conjugating and excreting bilirubin. Yes. We could also see this in patients who have massive hemolysis. We just referred to that a few moments ago, right? When we were talking about hematological. When there's massive blood destruction and the liver's a little behind in getting it all processed, it'll be floating around in the bloodstream and deposit in the skin. Best assessment? Sclera. All right, this is Mary's fun list, all right, of words used to describe GI problems. Anorexia, I don't want to eat. Nausea, I feel like I'm going to puke. Emesis, I did puke. Flatulence, which of course is my son's favorite words, especially in Boy Scouts. I am very flatulent today. The other scouts are looking at him. Is that a good thing? Oh yes, it's a very good thing. You're going to be experiencing it all day long. Oh. Yeah. I have gas. You don't want to hike behind those individuals. On the several-day backpacking trip, you really don't want to hike behind those individuals. Constipation, I can't go. Diarrhea, I'm pooping water. If it's children, sometimes they think they're dying. All that water's coming out, exploding out. It's very scary for them. Abdominal pain, my belly hurts. GI bleed, my poop is black and tarry. Wait till you have a patient. Bring in a jar. Other known uses for Skippy peanut butter jars. They're afraid they won't be able to tell you what's going on, so they collect. Some of them collect for a long time. It's like, thank you so much for sharing. You want to open the lid and let you experience. It's like, no. That's all right. Well, I just wanted you to be able to see that this is what's happening to me. Got the message. Can we get rid of that now? No, I think I'm going to keep it. I want to show the doctor. Okay. It is your stuff, so that's fine. Okay. Now, are there other things that can make the poop black and tarry? Iron. Yes. There are. Iron is one of them. Pepto-Bismol is another. So keep in mind that even though it looks like blood, and it might even smell like blood, don't take the lid off. That's my advice. Don't take the lid off. How is it that we must quantify whether it is blood or not? We're going to do a heme test, a guaiac. We're going to send it to the lab for checking for occult blood. That's how we quantify it. Okay? And occult means blood that we can't see. Is it possible that a patient can have what appears to be a really normal-looking poo, and it could have blood in it? Yeah. Yes. Okay, that's good. You need to know that. Now, ascites, my belly's full of fluid, and jaundice, I'm yellow. So that's just my fun way of going through what your patients might be complaining of. All right, so let's talk about some of the structures and their jobs. The esophagus is the tube that goes from your mouth to your stomach. It's supposed to transport the food that direction. It's supposed to have peristaltic movement this way, from the mouth down, not that way, this way, right? That's what's supposed to happen. We have a structure thereabouts at the level of the diaphragm called the lower esophageal sphincter. It's also called the cardiac sphincter by some people. And the function of that sphincter is very important to us. If it doesn't work right, what happens to all the food that goes down in your stomach? It backs up. It refluxes. So if the patient has problems with the integrity of their lower esophageal sphincter, or their stomach is up above their diaphragm or sliding back up and down, that's called a hiatal hernia. Those are problematic, and that's what we're going to talk about next and look at some pictures. Okay, well, pretty soon. Let's define a few more words. Dysphagia is somebody who has difficulty swallowing. Unfortunately, this can be a late sign of esophageal cancers or esophageal issues. If you have difficulty swallowing, that's one of those things that you want to get checked out. Not earlier, but later. What's another thing that could be causing difficulty swallowing? Not GI related at all. Stroke. Yes, you need to understand that that is a huge correlation and could be a sign and symptom of a stroke. If a patient is drooling, choking when they try to swallow, don't just think, okay, esophageal issue, also think they might have had a stroke. That is very, very common. Some of those patients have such severe issues with choking, they develop pneumonias. What types of pneumonias? Lower lobes or upper lobes? Upper lobe pneumonias are highly associated with aspiration, patients who have dysphagia. Okay. Esophageal diverticulum, I think most of the groups have come through. Remember that a diverticulum is an area of the esophagus that sticks out like that. It creates a pocket so that the tissue that used to be here is now out there, making this large pocket. So the wall thickness of that tissue is much thinner compared to the esophagus in general. If we get a collection of food or goodies in there, it's possible for that to get inflamed and then pop, rupture.
Would that feel like a heart attack?
It would feel very painful if you had contents of food and so forth going into your chest cavity. That would be very, very uncomfortable. And yes, it would cause chest pain, and they probably think they're having a heart attack. Would the pain get worse with a deep breath? Yes, it would. Would that lead us to believe that it's probably not cardiac?
Right.
Probably so. Not necessarily 100% of the time, but I'm trying to throw those pearls out for you that can help you with your assessment and coming to a diagnosis sooner rather than later. All right, hiatal hernia. With a hiatal hernia, you can have two kinds. You can have one where the stomach is definitely above the diaphragm at all times. Remember, the stomach's supposed to be below the diaphragm. It's supposed to be below it. So you can have one that's sort of stuck there, or you can have a hernia that slides in and out. And in that situation, the patient's going to have symptoms sometimes, then sometimes they don't. Whenever the stomach is above the diaphragm, it messes up the function of the lower esophageal sphincter. It doesn't work right. And causes the patient to have GERD. Can a patient have GERD without hiatal hernia? They can. But if they have a hiatal hernia, there's a very high probability they're going to develop GERD. By definition, the patient has food contents coming back up into their mouth within an hour of eating. If you have it, you know it. And what does it feel like when that stuff comes up? It burns really bad, and it causes tissue damage over time. So, pathophysiology for GERD, the lower esophageal sphincter usually keeps the gate closed. Once the food goes down, it's supposed to stay down. In patients with GERD, the gate is weak. It opens easily. The latch is broken. Okay, reflux occurs. Let's say I just ate something and then I bend over like this. Feels burning, nasty. Feels terrible, tastes terrible. Why does it feel terrible? It's acid. Okay, the pH of what we eat is not necessarily acid, but once it gets into the stomach, that's pH of 2. That's not supposed to be on our esophagus. It likes pH of 7. So when we throw pH of 2 on our esophagus, what happens to it? It gets burned. And as that starts to heal, it will shrink it down and it will scar it. Esophagitis becomes a problem. Now, some of the patients that have GERD have another issue of delayed emptying. Specifically, if they have ulcer disease, that can cause delayed emptying. And that means that the food stays inside the stomach for a longer period of time. And guess what? The longer the food stays in the stomach, the more opportunity there is for reflux. So this is not good. We don't want to have delayed emptying, and more acid is produced. All right, so signs and symptoms, heartburn. Yes, they're going to have more symptoms if they lay down. Does that make sense to you? Yeah. It makes sense to me too. Over time, the reflux of acid on the esophagus will cause swelling of the tissues, and as that tissue heals, it makes a scar and shrinks. Have you ever noticed you get a cut, you make a scab, it kind of shrinks down, and then you get a scar, and it's like smaller non-functional tissue? That's what happens in your esophagus. What happens to the motility in that area that's been shrunk down and scarred? The lumen becomes smaller, the motility is gone, and so the food is probably going to eventually start to get what? Stuck. How do we diagnose GERD? We can do an endoscopy looking for irritation and things like that. We can do a barium swallow where the patient takes opaque fluid, they swallow it down. Is it coming back up? What's going on with that? General treatments, antacids. Does antacids take away the reflux? No. It makes it less painful and less damaging. And antacids, remember, they're the drugs that reduce acid on contact. That's the ads you see on TV. That's the word, that's the better word. They neutralize acid on contact. We're not talking about Tagamet, Pepsid, and things like that. We're talking about Toms or Mylanta. Those are antacids. Neutralize acid on contact. Okay? Weight reduction can be helpful. Medications to improve emptying. That's Reglan or metoclopramide, which you might have heard about already, or you're going to hear about this or next week in Pharm. We give metoclopramide and Reglan to diabetics because they have gastroparesis as a result of autonomic neuropathy. They're nerves that innervate their internal organs that work without you thinking about it. Right? Do you think about digesting your food? No. It just happens for you, right? And in the diabetic, all of those nerves, those autonomic nerves, get destroyed and damaged. The nerves that innervate your heart, your lungs, and your GI system. So a diabetic has a loss of GI motility. Can they get GERD? Yes. Gastroparesis? Yes. So they would also benefit from that same medication which increases gastric emptying. Reglan or metoclopramide. So yes, we can give medications which coat ulcers. That's like a Pepto. Pepto is a coater. Or Carafate. You might be giving Carafate in the hospital. It's a purple pill. That is a coater. Coats the surface.
What's Zantac?
Zantac decreases acid production. Again, it doesn't take away GERD, but it reduces the acid production in the stomach, and so that can help that when they're refluxing, it's not as pH of 2.
Isn't that bad for digestion?
Well, this is an ongoing discussion, and I don't know if you talked about it or if you will in pharmacology. If we give patients medications which decrease acid production over time, does this make the patient more at risk of getting infections? One of the purposes of having pH of 2 in the gut is to kill pathogens. So if we stop acid production or limit acid production in the stomach by giving proton pump inhibitors or acid reduction agents, acid production decreasing agents, could we actually be predisposing that patient to infections which could come in through the GI tract? They're researching that. It's being written up in several journals right now. Interesting, isn't it? So could it be problematic? Yes. Right now, the physicians in the medical field feel that the benefits outweigh the risks. Could that change with evidence-based practice and research? Yes. Or research which provides for us evidence-based practice. All right. The stomach. What's the job of the stomach? Basically to receive the food stores, churn it all up, have an acid bath created, start digestion processes, kill any pathogens. The pyloric sphincter or the pylorus is the outgate from the stomach. If that's not working right, that certainly can cause problems. There are some hormones that are released as far as in stimulating acid production in the stomach. One important feature of the stomach is that it has a mucosal barrier. That's what keeps it from getting eaten alive. Remember, the pH of 2 in the stomach is normal for that area. And why the stomach doesn't get eaten up is because it has a mucosal barrier which protects it. Yes?
That mucosal barrier, can it be affected by dehydration or
Yes.
things that we're trying to get rid of mucus from other areas
I don't know about that one.
with the dehydration?
Dehydration can be an issue. The most common culprits for disruption of the mucosal barrier in the stomach are aspirin, the medications which are non-steroidal anti-inflammatory drugs. Aspirin, ibuprofen. The other culprit is H. pylori, the bacteria. And H. pylori is also under tremendous research. They don't know whether H. pylori is normal flora, which causes problems in some people, or not. They don't know. About half of the people that colonize H. pylori get ulcers and half don't. What is it that makes those half that get ulcers have that problem? So there's a lot of research going on with H. pylori. We know it's highly associated with ulcer disease.
You have to have other things for the H. pylori to actually become a problem.
Then other factors, such as, you have to have other factors in order for H. pylori to be a problem. What other factors?
You have GERD
GERD?
or
See, I don't know that. Nothing I've read yet has defined that for me. But I find it quite interesting that about half the people that colonize it get ulcers and half don't. They need to study both people, and then they're going to figure out what the mitigating factors are.
I know my girlfriend has it, but she's also gluten intolerant.
Okay, so gluten intolerant might be an issue. That's like a celiac disease patient, right? Unable to digest the protein in wheats and such.
H. pylori.
So those might be associated factors. We really don't know for sure yet.
They like acid.
They like
They
acid.
like very strong acid. So if you have overproduction of strong acid, the number of bacteria will grow, and then you have problems.
So if they like an acid environment, they probably love hanging out in the stomach. Yeah, I'm still learning about that. I haven't seen any definitive research which identifies all the complete relationships yet. But those are the two prominent things that we usually identify. And anything that disrupts that mucosal barrier can lead to problems in the stomach. Okay, so disorders of the stomach. The patient may have gastritis or inflammation of the stomach. This may be associated with medications. It might be associated with disease processes. One of them that's highly associated is renal failure. It is the kidney which clears the hormone gastrin from your body. So if you have kidney failure, what happens to the level of gastrin in your bloodstream? It goes up, and therefore you will secrete more acid. So that type of patient might be predisposed to gastritis. Peptic ulcer disease, or PUD, you'll see PUD written on the chart. Peptic ulcer disease is a term which encompasses ulcer disease in the esophagus, the stomach, or the small intestines. So if the patient has PUD, they could have ulcer disease in any of those areas. These are a couple of pictures of ulcers which are seen by endoscopic examination. Okay, they don't look very pretty, huh? They look pretty diseased. The issue that we worry about with ulcers is, are they surface or are they deep? Right? Either one can bleed, surface or deep. Which one's more dangerous? Deep. The reason because as you go deeper into the tissue, you hit the blood supply. And once you erode through the blood supply, that's what creates the active GI bleeding that can kill people. The surface bleeding is not usually as serious. They don't worry about that. But the deep ulcers that go into the blood supply are very dangerous. Now, Curling's ulcers are a form of stress ulcers. And I'm not talking about psychological stress. Not psychological stress. I'm talking about physiological stress. The patient who has a drop in blood pressure, the patient that has some sort of traumatic injury, that causes the bowels to become ischemic. It causes all the tissues to become ischemic. What happens in the bowels, though, is that ischemic tissue will slough and bleed a little bit. And that's why all of our patients in the hospital are on protonics or Pepsid. We are decreasing acid production in case they develop physiological stress ulcers. It decreases the risk. Have you ever tried to explain to your clinical instructor why every patient you take care of is on that? It's prophy. It's prevention. It helps prevent the formation of stress ulcers or Curling's ulcers. How do we identify this patient? This is the one who loses a little bit of blood every day, right? They start out at 14 and 40, and then they go to 13 and 36, and then they go to 12 and 33, and then they're 10 and 30, and then they're 9 and 27, and we're like, what the crap is going on? There's no active sites of bleeding, and the amount of blood they're losing through the GI tract is just small enough that we can't see black tarry stools. But guess what? If we sent their stool for occult blood, it would be positive. This happens to a lot of our patients in the hospital. No obvious blood loss, but each day they drop a little and eventually may require a blood transfusion. That's the reason why we all give our Pepsid, Protonics, or whatever the acid reduction agent of the week is in the facility where you work. And some of you know what I'm talking about. All of a sudden the formulary changes and every patient who was on any of those agents has to be on this because that's what we have in the formulary. Yes? Yes. Okay. So this is a painless GI bleeding. It doesn't hurt the patient. You see that drop over time. So that might help you with your clinical preparation. The patient came in and had some sort of event and now we see that H&H dropping just a little bit every day. It might be this type of a scenario. Okay, this picture talks about the depth of the lesions. Again, if we have an erosive lesion, that's going to be just on the surface. They'll talk about that in their endoscopic report. Erosive lesions, just surface, they weep a little bit. Not usually going to cause active, serious bleeding. Then we have these true ulcers, which can erode all the way down into the muscularis level. The muscularis level is where we have the blood supply. That's the problem. If we have erosion so deep that we hit the blood supply, we're going to get active bleeding. If we have erosion so deep that it goes through the full thickness of the bowel, then we get perforation. So the serious deep ulcers can cause the active GI bleeding and perforation. Okay, so what's the worst thing that happens if they perforate? Sepsis peritonitis. If it goes all the way through the bowel wall, then all that nice E. coli that lives in there that's, therapeutic and normal flora for us, spills into our sterile peritoneal cavity. Oh, that's going to be a bad day. Very bad day for you and the patient. What clinical assessment finding helps us find perforation? The firm, board-like abdomen. I feel as hard as a rock. Firm, board-like abdomen. That is diagnostic of a patient who has perforated. And it's very bad and very difficult to clear up. All right. Rather than talking about different types of ulcers, I like to sort of go through the list of name that ulcer, reminding ourselves that infection with H. pylori and ingestion of nonsteroidal anti-inflammatory drugs such as aspirin and Motrin are high culprits. If I get a GI bleed, I'm always going to ask them, do you have pain or arthritis? Do you take over-the-counter medications for that? And by the way, what type do you take? A high percentage of these patients are self-medicating with aspirin or Motrin. Will Tylenol cause this problem? No. Okay, it is the non-steroidal anti-inflammatory medications. All right, so patients that have ulcers, they might be gastric or duodenal. This list of questions can help us determine which one they have. The clinical symptoms are stratified to a degree. So rather than giving you a full slide of each, I just put down the definitive questions. So if you don't know, we're just going to go through the guessing game. If the patient tells you that when I eat food I feel better, which type of ulcer is that? Okay, well that was a spattering of both. So I will tell you that when I eat food it feels better is a duodenal ulcer. When we put food in the stomach and the acid is staying in the stomach digesting food, it is not dripping on the duodenal area. And therefore, when that patient eats a cracker or eats a piece of food, they feel better. All right, so you can guess now. When I eat food, it hurts worse. That's a gastric ulcer patient. Because there's food put in the stomach, that can rub against the ulcers. And when we put food in the stomach, they make more acid. So they feel worse when they eat. Okay? I always hurt at night. What is it that you're doing at night?
Laying down.
You're laying down and usually going to, that's all the clue.
On your side. So it's duodenal.
It's duodenal. The patients who hurt at night are usually duodenal. There's a slow leak of acid that's going on, and at night you don't eat. Those are the patients that end up putting a little bit of food on their bedside table because they know if they take a cracker or something like that, their pain will go down and they can get back to sleep. Okay? Always hurt at night. Which one is related to an oversecretion of acid? Actually, duodenal. Most associated with oversecretion of acid. Remember, your stomach is an acid vault. It's meant to deal with acid. It has a nice mucosal barrier. It's supposed to deal with pH of 2. Your duodenum isn't. In the duodenum is the area where all the digestive enzymes come up, and rapidly that pH of 2 goes up to 7 for absorption. Your duodenum is not designed to have acid on it all the time and is the one that breaks down more in relationship to oversecretion of acid. Constant problem, no remissions. That's gastric until we take away the cause. So I like this list of questions as far as learning rather than just going through separate slides. And this is a picture of little H. pylori bugs growing and doing what they do. And as they grow and reproduce, the literature tells you that they secrete something, byproducts, waste products, and apparently it's that breaks down the mucosal barrier that causes the problem with H. pylori. So patients that are known to have H. pylori, they put them on coating drugs and antibiotics, try to kill the H. pylori and restore the coat. Okay, ulcer treatments, common list of things we might see: antacids, sulcrophate or carafate, which is a coating drug, any of the H2 receptor blockers, Tagamet, Pepcid, proton pump inhibitors, the purple pill, all those types of things which reduce acid production. Now these are things that you might not think about, and these are autonomic nervous system issues. Remember that it's the parasympathetic nervous system when stimulated that causes feeding and breathing. Activation of the GI system, yes? So if we block that, if we block the parasympathetic nervous system stimulation to the gut, we're going to stop acid production. We can do that by giving medications like atropine. Atropine is a vagolytic. It blocks the parasympathetic nervous system. Therefore, acid production goes down. Formations of secretions goes down. Motility goes down. All right? Or we can actually cut the nerve. If we cut the vagus nerve, which is the parasympathetic fiber going to the gut, we call that a vagotomy. If we do a vagotomy, it's the same thing as giving a drug. We take away the parasympathetic innervation to the gut. Acid production will go down. Motility will go down. Secretions will go down. That used to be all they did when I got out of school. They didn't have Tagamet, Pepcid, and all that good stuff, all these medications. Patients who had ulcers and GERD went in and got a vagotomy and a pyloroplasty. That was all they had available. They would cut the nerve and they'd open up the outlet to the stomach. By opening up the outlet to the stomach, the stuff flushes through faster. Right? Takes care of any of those delayed emptying issues. So that was the old treatment. I don't hardly see anybody getting those anymore, do you? May not have even heard of them. Practice has really changed. The other thing they can do is cut out the antrum of the stomach. That's where most of the acid is produced. So these days, management is quite conservative, based on pharmacological agents and so forth, with surgery as a last resort.